Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing health care to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation, Overactive Bladder, Causes, Symptoms, and Treatment, presented by Dr. Mark Hsu, Urologist with Washington Township Medical Foundation. And now, please welcome Dr. Hsu.
Good evening, everybody. My name is Dr. Mark Hsu. I'm one of the urologists at Washington Township Medical Foundation. Thank you very much for joining me this evening on our talk about overactive bladder, which I'll refer to as OAB throughout this presentation. This is one of the most common issues that we see in our clinic today and one of the most common issues that we see in urology. So the purpose of this talk is to give an overview about OAB, the typical symptoms that can occur with that, the evaluation that we conduct in our clinic, as well as an overview of the treatment options that we have to treat this condition. So I looked up the official definition of OAB, and per the International Urogynecologic Association and the International Continence Society, this is the definition. It says, urinary urgency, usually accompanied by frequency and nocturia, with or without urgency, urinary incontinence in the absence of UTI. Well, that's a lot of words, right? So let's try to translate that medicalese into something more understandable in English. So let's simplify OAB to really 4 bothersome types of symptoms. So the first one is frequency. So going to urinate more often than you want to. Okay, and now the common question is, what is the average number? Well, there is no real correct number of times to urinate per day, but I would say the extremes are noticeable. So for example, if you only urinated once or twice a day, that would be probably considered on the low side, and if you were urinating every hour during the day or the nighttime, that would be considered probably more on the excessive side. So somewhere in the middle, I would say if we were to have a spectrum, it would probably be anywhere between 5 to 8 times a day would probably capture most people. So that would be one measure. Urgency is defined as the need to urinate more quickly than you would anticipate. So if you were to say you have the need to urinate, but then you feel like the urine was about to come out a lot sooner than you usually would like it to, then that would be subjectively defined as urgency by how you feel. Nocturia is the medical word for waking up at night to urinate. The sensation of urination at nighttime wakes you up. This is usually more bothersome to people and is defined as usually at least twice a night, but some people can have more, and that can interfere with good sleep quality. And finally, the one called urgent continence is basically referring to urinary accidents. So if you were trying to make it, you had the sensation of needing to urinate, and then the urine was basically coming out before you could make it to the bathroom, that's what we medically would define as urgent continence. So OAB is quite common. Epidemiological studies will show that up to 1 in 6 adults can have OAB-type symptoms. And as you get into the golden years, that can become more common. It's estimated that even up to 40% of the elderly can have OAB symptoms. Now, this condition in itself is not fatal, but it can significantly impact someone's quality of life. So the most bothered patients will tell me in clinic that they know exactly where all the bathrooms are on their daily routine. They basically chart their whole day through to each bathroom. And as you would expect, this can cause a lot of social embarrassment in social settings. So, being the fear of having wet clothes from the urine accidents or fearing someone's going to smell the urine, and then having to change or bring liners or pads or Depends as protection against the leakage going onto the clothes. So as one would expect, this can have a significant negative impact on people's people's ability to enjoy the activities they like doing, their mood in general, the sleep quality if this is occurring at night, and of course the finances and having to purchase supplies to manage this condition. One of the very small benefits of COVID was that some of these OAB patients said, well, I was in quarantine or I couldn't go anywhere, so at least the bathroom was really close at home, so I was able to do that. So it seemed to alleviate some of the symptoms they had from OAB, but now they relay their concerns that as they hopefully are going out to the world as it opens up, hopefully, that they may start going back to some of the fears of going back outside where they're not able to be near a bathroom so quickly. So in taking a history about someone comes into the clinic with OAB, we want to make sure we get a good history to and make sure there's no obvious acute or reversible causes that can quickly resolve symptoms. One would be the acuity. How soon did it happen? If something happened more recently, then it might pique my interest to make sure there's not something like a urine infection. Okay, so UTIs. Versus something that's more chronic, you might think this might be more of a long-standing kind of issue. We also want to assess for hematuria, which is the medical word for blood in the urine. If there is some associated blood in the urine that we see on evaluation, we want to make sure that this is not the early sign of something like the C word or like a kidney stone or some other potential issue that needs to be addressed. Men are a special case, and I have a slide on that in a little bit. Men can have the OAB symptoms, but they also have a prostate, and that's different. That makes them different from women in one of the ways, of course. But the prostate is an organ that sits right below the bladder in men, and as that grows, that can cause more blockage for the bladder, and the bladder's got to work a lot harder, and that can create OAB symptoms. So we have to want to get a good history about that as well. The next thing is about medications. We want to see what kind of medications can sometimes contribute to urinary bother. And one of the most common culprits can be diuretics. So some people who are in a fluid positive state from some medical conditions, such as with the heart or liver, they're going to be prescribed medications to try to dump more fluid out from their body. But that can exacerbate some of the urinary symptoms that in the OAB symptom complex. Lifestyle is a big thing that we also want to delve into. So looking at the types of fluids that one drinks in terms of the amounts and the types of fluids. So certain beverages such as coffee and tea and alcohol, those will make you want to urinate more. They're basically like diuretics that make you want to urinate more and more frequently and more urgently. Okay. And then finally, one of the issues is about mobility. So sometimes may not even be a urinary issue, but a life kind of logistics issue. So if someone is not as mobile as they once used to be, you might be able to run to the bathroom in less than 30 seconds normally. But if it's hard to get to the bathroom now, then we maybe a simple logistics issue like having a commode nearby so that you can go in those situations. The medical history is also important in terms of what's gone on in the past. Things that we do know well from research that things like having a stroke or neurodegenerative conditions can contribute to an OAB type of complex with how you urinate. People with uncontrolled diabetes, that can be the sole factor in why someone may have maybe drinking a lot of fluids and also urinating quite often. And finally, people who have spinal cord injuries will have issues with urination. We want to better understand that. In the surgical history, so people who've had pelvic surgery or radiation, that can also affect the innervation. So one of the things I will touch on a little bit later in talk is talking about how the brain talks to the bladder through signaling. So kind of thinking about that mechanism and some of the treatment options that go there will influence that. So the physical exam, just to be brief, this basically supports the things that we just described in the history. So looking for evidence of prior surgery with the scars. The lower extremity edema is a medical term for fluid. If you're fluid positive, it can sometimes pool in the legs. That can be a sign of saying that needs to be managed. As well as a pelvic exam, there's some things in terms of pelvic support, such as pelvic prolapse. So sometimes in ladies, older ladies, they can have Some things drop into the vaginal area, such as the bladder or the uterus or the rectum or intestines. That can kind of upset the balance of things there and cause urinary changes. A condition called atrophic vaginitis, where in postmenopausal women, the vaginal mucosa, the area outside, is not as robust as it used to be, and that can also contribute to urinary issues. We also want to assess how strong someone's pelvic musculature is, and strengthening those muscles in the OAB area can help if we're looking at behavioral therapies. And finally, a condition called stress incontinence, and seeing if they were coughing or sneezing or doing some kind of activity if urine leaks out, and that's a little bit of a different condition. All right, and a neurologic exam as indicated if we're suspecting some neurologic issues. The labs that we'll do in our clinic, so checking in the urine studies to make sure there's no obvious urine infection or looking for blood in the urine that may cue us in to do further workup. We also will do what's called bladder scans or post-void residuals. So in case someone says they're having some urinary issues, making sure that they're emptying sufficiently. If we see a lot of urine in there after they think one is thinking that they're done with urination, that cues us into doing more workup and figure out if there's something else going on. And urodynamics is one of our studies that we can do. It's like a functional study on looking how the bladder reacts to filling with fluid and emptying and more complex cases. So this is one of the slides I wanted just to point attention to in terms of stress incontinence. So this is a little bit different from the urge incontinence, but just wanted to point it out because I'm sure some patients will experience this and want to kind of know what's going on. So this, by definition, is an activity-induced leakage of urine through increased abdominal pressure. So if you're doing something like exercising or laughing or coughing or sneezing, that sudden pressure can cause increased force through. So here's the bladder, and you have a sphincter muscle that controls when you don't want to urinate, and the urethra is down here. If you were to have a sudden pressure through activity and your sphincter or your muscles weren't able to contain the increased pressure, then the urine leaks out that way. Okay, so this is a different condition from OAB, but there's something that we can address with things like exercise, and there's things like slings as well as bulking injections we can give into the sphincter to help with that. So, potentially another talk at some point in the future, but this is a condition that can sometimes coincide with OAB, and just to be aware of that. So another consideration is in men. So going back to the diagram here, so women just have this bladder and then the urethra, but guys have a prostate here. So this prostate in a lot of men, as they get to the older years, can start enlarging. So not only does it get wider, but it also gets thinner on the inside here. So the bladder here is trying to squeeze urine through a tight, small a channel through in the prostate. But as people get older, that prostate gets bigger, it becomes a lot tighter. So this bladder as a muscle has got to work a lot harder to squeeze this urine through this tight area, so it becomes very muscular and thickened, and we call trabeculated in medicine. And these can be the symptoms that not only can men have a weak, say they have a weaker stream, but they also can't hold it as often. They're going a lot more often. They can't hold it very long. They're waking up at night, and it's because this bladder is working a lot harder than it wants to, and the efficiency is also not as good as it would be in the normal state. Okay, so. So it's important to know, for the urologist or the physician to kind of differentiate and kind of figure out, is the OABs and symptoms, are they secondary to the prostate issue, where most of the time it is, and if we deal with the prostate first, the bladder doesn't have to work so hard, so it starts to, to relax a little bit more, it doesn't have to work so hard, and most symptoms, most of the time, both types of symptoms get better. But sometimes in men, it can be a primary bladder issue as well. So I'll now go over some of the treatment options that we do offer here. So just to give you some a little bit of an outline here, the first one will be about lifestyle measures here. So we'll kind of talk about some lifestyle and behavioral therapies that can be implemented. And the next set, we'll talk about some medication options that are available. There's 2 main types of medications that we currently offer. And finally, 3 more procedural oriented options that we offer for OAB if patients are not responding to medications. So one of the first things I'll do with my patients when they first come to clinic is get what's called a void diary. It's a very, very simple document. I mean, all I have is just a line of, show me, when someone tells me they come and they pee all the time and they can't hold it. And I'm like, well, how often is often, right? So having them chart what they're doing for a couple of days is actually very informative to me. So what I'll do is I'll give a person a piece of paper. I give them a container to measure the urine in. I'll say, okay, give me a few days where for 24 hours, every time you drink something, you write down how much you're drinking, at what time, and then every time you urinate, you're going to pee into the container. You're going to see how much comes out. You write it down. You dump it out, and repeat. Okay, so this gives me an idea exactly about the frequency of how someone's urinating during the daytime versus the nighttime. The typical void volume, so urinating a very small amount with a lot of frequency versus urinating a lot, kind of can tell me some more information. Tells me about how much the bladder can hold, okay, and then the most that it can hold is essentially the capacity. And also, if someone's complaining about urinating a lot at nighttime, seeing the splits of how much one is urinating versus the daytime and the nighttime is very useful in guiding what my next steps are. This set is about just some of the basic strategies that can be employed before we start going into medicines and procedures. One of them is about really counseling, looking at the diary and seeing what kind of fluids one is drinking and the timing. So someone's drinking a lot of beers or a lot of sodas, and I'll tell people to really try to work on cutting that down, substitute with some more plain things like water. So looking at how much someone is drinking and adjusting that when we look at the diary is helpful. Also look at the timing, right? So if someone's saying they're urinating a lot at night, then we want to try to limit how much someone is drinking before bedtime. So kind of common sense, right? What must go in must come out. So try to drink less before you go to bed so less can come out, right? The next strategy would be called time voiding. So taking the opportunity to urinate when you have the bathroom nearby, right? So let's say, we were about to leave home to do some errands or you're about to leave the restaurant. Well, you may not want to urinate at that point, but you may not know when the next bathroom opportunity is. So take the opportunity to go ahead and empty your bladder at that time when you have the chance, so that you have less of these situations where you're in the middle of something and you need to go to the bathroom and you don't know where it is, right? So that's a very simple strategy to use. Another one is called bladder training. So bladder training is an idea for a very motivated patient. Let's say someone has a baseline where they're urinating every hour and they want to try to increase it to maybe 2 to 3 hours eventually. So very gradually you increase the interval. Let's say we target an hour and 15 minutes between the times you go to the bathroom. So you try to really target that time. If you have the urge, you try to suppress it. So you can try to squeeze the muscles, kind of deep, kind of meditative-like breathing exercises to try to suppress that urge. Now, of course, if you have to go, you have to go, but in a way, trying to slowly acclimate your bladder to holding the urine for a longer amount of time to get there. Now, it actually can be quite successful, but you do have to be pretty motivated to make progress. And finally, there are some pelvic floor exercises that can be helpful. So the most common one that I'm sure childbearing women are familiar with is the Kegel exercise. So that's the one where if you were to be urinating in the bathroom and then someone knocked on the door and said, "Who's that?" and you said, and then you stopped your stream midstream. Those muscles that you're using for that, you can practice contracting those muscles. So squeezing that, holding it for a good 5 to 10 seconds, and then relaxing. And then doing it again, and then relaxing. So, doing a couple sets of 10 repetitions a day. You can do that, in your daily commute, or just when no one's even around, or you can do it when someone's around. It's pretty easy to do. You want to focus on using the muscles, just the pelvic muscles. You don't want to be using your abdomen, your butt, your thigh. You want to just really focus on those particular muscles that you use to stop the urination. All right, so the next level of therapy, if the behavioral therapies are not responding, is to use medication. So this is the first type of medication called anticholinergic. So a very simple way I'm going to describe this is, again, we talked about the brain is signaling, is sending neurotransmitter or kind of brain chemicals down to talk to your organs about what to do. Okay, so there's two main ones, right? And for the bladder, there's ones that make the bladder squeeze, and there's ones that make it relax. Okay, so for this one, there's this is the first class of medications that have been out a long time. I've written down a few examples of the most common ones, and they basically what they do is inhibit, or they kind of block the receptors that make the bladder want to squeeze. Okay, so if you're inhibiting the squeezing, you're relaxing the bladder, right? So this is, again, the most common type of medication that most people will probably usually start out with. There are a few side effects to be aware of. Okay, the most common one by far is dry mouth, and other ones can include constipation. And there can also be some people who can have CNS or central nervous system side effects, so feeling a little foggy or dizzy, that can be related to this. Okay, and then finally, we don't want to give this to someone who is having trouble emptying the bladder, because if we're relaxing the bladder even more, then we could risk putting them in retention where they can't even urinate at all, and that would be definitely not the right thing to do. The second class of medications focuses on the other way. So in terms of the brain chemicals telling a bladder to relax, then we have a medication class that tells it to tries to get the medication to bind those receptors in the bladder to relax. And this is called the beta-3 agonist. The main medication that's out in the market right now is called mirabegron. And what this does, it binds those receptors and really relaxes that bladder. This is generally my go-to for patients, especially if we're concerned about the side effect profiles of the other class of medication I discussed. And the main one really is a small increase in blood pressure. So as long as someone does not have uncontrolled hypertension or very significant cardiac history, I'm generally pretty okay with trying this medication out. So the final thing now, this is going to the three procedural options that we can go offer patients if the medications have not given enough effect. So again, going back to this whole brain bladder paradigm, trying to help the signaling, improve the signaling from the brain to the bladder. So this technique is called posterior tibial nerve stimulation, or PTNS is what we call it in brief. And we basically stimulate the tibial nerve, and this is basically a nerve that runs, the point we stimulate is above the ankle, is right behind one of the main leg bones called the tibia, okay? And actually, in fact, this is an acupuncture point that people will use. If you were to go see an acupuncturist for OAB, this would be one of the points of interest. But basically, they do stick a small needle into that particular point, and then you just run a little bit of electrical current. And that electrical current activates this nerve, and this nerve does communicate all the way back up near one of the sacral nerves, or one of the nerves that runs out from the spinal cord, and that talks to the bladder and tries to make it more quiet. Okay, so this is about a 30-minute treatment once a week. And then at that point, we will reassess and see if that's helped. If that has helped, then we can go on to a maintenance therapy program where they get a treatment every 3 to 4 weeks. This is a type of treatment that does require ongoing treatment because if enough time passes, the effect will go away. Okay. The risks are relatively small for this technique. I mean, I think the success rate is a little bit lower than the other two procedures, but if someone wants to kind of just dip their toes and say, well, I'm going to try this, I think the biggest risk is usually I tell people it's your time, and it may not work. So, okay. Bladder Botox is the next technique that we can offer for OAB patients. And so everyone, I'm sure, is familiar with Botox. For the people who want to get rid of the wrinkles for a period of time and they want to inject Botox into their face so that they can look 30 years younger. well, we can also inject Botox into your bladder to make your bladder feel 30 years younger, right? So what we do is we put a camera camera into the bladder in the office, and we have a template where we inject the bladder into the muscle with the Botox. Okay, so usually a very quick procedure, just several minutes. And what that does directly is that now, just like if it relaxes the wrinkles in the face, it relaxes the bladder muscle, so it doesn't want to squeeze as often or as urgently as one would, hopefully not want to. Okay. This does wear off as well as, it does wear off over time, but it does usually last for several months, usually about 4 to 6 months on average. So if patients do have a good benefit with the Botox, then when it starts wearing off, then they contact the office and we schedule the next procedure. There are some risks to this procedure, including bleeding, because we are, in fact, sticking a needle into the bladder. So most of the time that bleeding stops fairly quickly, so we just have to be careful we stop the blood thinners if there's any blood thinners that one's taking before that. There is, of course, a risk of infection, but it's small. There is about a 3 to 6% risk of what's called urinary retention. So if the Botox works too well, you would have the opposite effect. So it'd be so relaxed that it's actually hard to urinate. So in some cases, one might even need to have a catheter temporarily to sufficiently empty the bladder. But as you'll recall, this is not a permanent thing, because anything, the Botox will wear off, so any benefits or any adverse effects would eventually wear off, and you would go back to where you are before you had the treatment. This is a great option for one segment of my clinic patients who have what's called a neurogenic bladder. So if we know someone has a spinal cord issue or spinal cord injury, and they, in fact, do empty their bladder by catheterizing regularly, but they have leakages in between, we actually want to almost put them in retention. We purposely want to quiet the bladder by injecting enough Botox so that the bladder is quiet, so that one can catheterize themselves without any problems in between. The final technique that I'll discuss for OAB is called sacral neuromodulation. So this is more of a central technique for the nervous system, that brain-bladder communication, to really try to get that nerve that's talking to the bladder to be quieter, not fire off so much. Okay, so this nerve, we basically are testing what's called the S3 nerve. It's one of the sacral nerves that comes out from the spinal cord, comes down and talks to the bladder, and as well as the rectum as well. And they've shown in some mouse studies that when you stimulate this nerve, the bladder signaling gets a lot quieter. So that's how this kind of came about in translation to humans. It's been around since 1997, and it's been clinically proven to stop or reduce the accidents. I would say we've had probably a 80% approximate success rate with this technique. I would say that's pretty similar to the bladder Botox in terms of having symptoms improve. So if we decided that we're interested in this technique, there's typically 2 stages. One is a test trial, and then before we decide if we wanted to have that as an ongoing treatment. So the test trial is kind of like a try it before you buy it. So if one was interested, they would come to our office. They lie on their stomach. We basically numb the skin with some anesthetic, and then we're basically using our anatomic landmarks to find this S3 nerve. Once we find that nerve, we put a little test wire down there. We put a bunch of packaging on top of that. And then we give you a little remote. It's like a small little cell phone with some programming in terms of the amount of stimulation and a couple of different settings that one can try. And so we talked about having the void diary to kind of see what someone's baseline is. And then we'll do another baseline void diary after, during this trial for about 3 to 5 days, and see if we're getting at least a 50% improvement in the OAB symptoms. And once we come back, we just take everything out, and you go back to where you were before this whole trial. So it's a very simple thing just to say, hey, if we try to help the nerve signaling and improve it or unscramble it, then maybe we can help your quality of life with that. So if the test trial is successful and we want to proceed to the next step, then we basically have a small outpatient procedure where we put the wire into the proximity or near that target nerve that we've been talking about, the S3 nerve. And then we also then attach a battery nearby, and that will connect to this wire, and basically will power it for the duration of that time. Now, just in the last month, they've come out with a battery that can last up to 10 to 15 years before being needed to be replaced. So, so this again is an X-ray showing that what the anatomy of everything would be at the end. But this is kind of, if you can kind of compare it to, say, the first technique with the PTNS, this takes a little bit more investment up front. But if someone is truly happy with the results of this technique, I mean, basically it's kind of set it and forget it, and the benefits can last for many, many years without maintenance treatments. So in summary, hopefully I've conveyed to you, to the audience today about OAB, an overview about the types of symptoms, to have evaluation that we do if you were to come to the clinic, as well as over the options that we can offer in terms of medications and procedures. So with that, I thank you very much for your time, and I'll take questions.
Thank you, Dr. Hsu. We do have a few questions. People are encouraged to stay hydrated. How do you balance staying hydrated with constant bathroom breaks?
Yeah, that can be a pretty tricky issue because some people, I think that in medicine, people will, sometimes you hear you need to drink more water. Well, then some people will say, well, if you drink too much water, you're going to urinate too much too. So it's a little bit of a balance. I mean, there are some medical conditions. Let's say your heart is not working so well, so sometimes you'll be fluid restricted, so you'll have to follow that. But you also want to stay well hydrated enough, because sometimes that can be an issue for UTIs as well. So it is a little bit of a balance, and I think it's trying to find that equilibrium where you're drinking enough to keep yourself hydrated, but not so much that it's triggering more severe OAB symptoms.
Thank you. The next question we have is, why is anxiety associated with an active bladder, an overactive bladder?
Yeah, so anxiety can be just basically like a stress response. And so I think it's just more if you're anxious and you had some urine in your bladder, your muscles are more tightened up, it would, if someone already does have OAB, it would just kind of make the situation worse. So I think that's what is going on with that.
Okay. And another question we have is, if I think I have OAB, what would be the best first steps to take?
Yeah, I think just to kind of hammer home the points of our talk, I think it's good to do a good lifestyle review of yourself, in terms of kind of thinking about what fluids you're drinking and how much and the timing. I think that's a common thing now. Also looking at the medications that we talked about, and if someone's waking up too much at night and that's bothering them, and I think again the first few things I'll say is, what are you drinking and how much are you drinking a few hours before you go to bed? Because if you're drinking a lot of fluids, or you're drinking things like tea and coffee and beer and things like that, like at certain times, I'll see that in the void diaries with people. They say, I drank like 3 cups of coffee, and then they're urinating every hour after that. Well, you say, sometimes is that knowing or being aware that when I drink that coffee, I may, pay that price, right, for a few hours after that.
Thank you. Thank you, Dr. Hsu, for addressing all those questions. These are questions that we have every day, and we don't always have the resources to ask them. So thank you for being here today to answer our questions and to give this presentation. And this concludes our program. Thank you again for this insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.